Welcome, everyone. Thank you for joining us. Our topic today is Rethinking Infection Vigilance in a Post-Pandemic World. The global pandemic, with its still unfolding morbidity and mortality consequences and lethal potential, has further raised the bar on already conscientious nurses and other healthcare providers at the patient point of care. The very technology, which has vastly improved patient outcomes, facilitated patient tracking and diagnosis, and greatly diminished the risk of medical error, does itself present a source of infection if not considered in the same realm as other contamination risks. Today, an interdisciplinary panel of clinical experts from Island Health and the Mayo Clinic, as well as industry leaders from HP, will help us understand how we need to rethink clinical and hospital infection vigilance in a post-pandemic world. My name is Lily Jelinas, Editor-in-Chief for American Nurse, the official journal of the American Nurses Association. I'll be serving as webinar moderator. To maximize your webinar experience, please take note of these important items before we get started. First, today's webinar will last 60 minutes. You can submit your comments and questions to info@myamericanNurse.com. Second, a full recording of this webinar will be available within 72 hours, and all attendees will receive the link by email. The replay will be available on demand for 1 full year, and you can access it free of charge as often as you need. Let's meet our panelists. Today's speakers are Dr. Sean Spina, Coordinator of Clinical Pharmacy Services at Island Health in Victoria, British Columbia, Canada. Sandra Dunford, Infection Prevention and Control Consultant, also at Island Health in Victoria, British Columbia, Canada. Dr. Ellie Barberi, Chair of Infectious Diseases at the Mayo Clinic, Rochester, Minnesota. Do Cly, Senior Infection Preventionist for the Clorox Company and lecturer for The Ohio State University. Daniel Colling, Global Lead Healthcare Industry Solutions, HP Inc. The learning objectives for today. At the conclusion of this webinar, the attendees will possess an elevated awareness of the latest data on the incidence and patient safety impact of healthcare-acquired infections, understand the risks which IT and Internet of Things devices represent as being among the most likely vectors of HAIs and viral pathogens in their technology and device-rich hospital and clinic environments. Recognize their ever more critical role in and ownership of the mitigation of infection risk and the key actions which that increased responsibility mandates. Feel more empowered to serve as frontline change agents and advocates in their clinical settings to institutionalize aseptic best practices in these seldom appreciated risk areas, particularly at critical junctures at the intersection of technology and patient care. To understand the importance and the implications of what we'll be discussing today, let's look at HAI's risk by the numbers. Healthcare-associated infections are a significant problem that cause costly and deadly impacts to patients, their families, and care providers interacting with infected patients. In the United States, HAIs infect 1 in 31 patients, account for 1.7 million infections, and lead to approximately 99,000 deaths each year, meaning that HAIs cause more fatalities than car accidents, according to the CDC, and they cost $5.4 billion in hospitalization. And consider tech and transmission vectors. Essential IT, wearables, and Internet of Things devices are often overlooked as infection vectors in healthcare environments. A French research survey explored the presence of viral pathogens on healthcare workers' mobile phones. Virus RNA was detected on 38.5% of them. A Canadian research study explored the presence of microbial pathogens on wearable and Internet of Things devices. Only 45% of clinicians cleaned their smartphones at least weekly, and bacterial isolates detected on 22% of IoT and wearable devices. So look at studies that draw the linkage between awareness and hygiene as a disconnect. In one study, 100% of study participants said they knew their mobile phone could be host infectious agents, and 64% used their phones during patient care, but of them, greater than 28% never performed hand hygiene before mobile phone use. 37% admitted they'd never performed it after mobile phone use. So let's bring in Daniel Colling.
Thank you so much, Lily. I'd like to ask Doe Clay, who is with Clorox Healthcare and a partner with HP. Doe, what are some of the patient risks that healthcare-associated infections can result in?
Hey, thanks, Daniel. You know, HAIs are the epitome of patient safety issues, and they're a major cause of morbidity and mortality. Poor infection prevention and control practices lead to transmission of pathogens, including drug-resistant ones. The CDC's 2019 Antimicrobial Threat Report highlighted the growing problem of antimicrobial resistance with few new drugs to treat them on the horizon. In fact, the CDC predicts that by the year 2050, deaths from antimicrobial-resistant infections will surpass those from all cancers. Now, it's well documented that HAIs increase length of stay in the hospital. Studies indicate this increase is somewhere between 3 and 23 days, depending on the HAI. Additionally, longer hospital stays coupled with invasive procedures and devices only add to the HAI risk. Now, not surprisingly, an HAI can result in human suffering and can forever change a patient's life. They can cause long-term health issues and disability, such as the recurrent disease that we often see with C. difficile. Additionally, HAIs often result in a negative patient experience. The patient entrusts us with the health issue that brought them in, and that trust can be quickly eroded when we fail to protect them from harm such as HAIs. Trust is an expensive thing. It takes years to earn, but can be lost in a single incident. So with that, I think we're ready to take a closer look at public reporting of HAIs. Next slide, please. So in the early 2000s, some states passed laws requiring public reporting of selected HAIs. And by 2011, the Centers for Medicare and Medicaid, or CMS, implemented national public reporting of HAIs, beginning with central line-associated bloodstream infections, or CLABSI. As of 2015, hospitals were required to report 8 types of HAIs, ranging from selected surgical site infections to C. difficile, and individual states may require reporting of additional HAIs. This data can be viewed by anyone at the hospitalcompare.gov website. This HAI data is used by many agencies. For example, CMS uses this data to determine reimbursement or payment to hospitals. The Leapfrog Group, a nonprofit founded by large employers and other healthcare purchasers, utilize HAI and other patient safety data to improve quality and safety in healthcare. Based on results of an annual survey, Leapfrog assigns a safety letter grade to the hospital. The annual survey looks at both process and outcomes, including hand hygiene practices and 5 selected HAIs. The information provided by Leapfrog allows purchasers, including health insurance plans, the ability to select high-value care. So as you can imagine, public reporting of HAIs and other patient safety data can greatly impact a facility's reputation. This data can also impact a facility financially. Next slide, please. The Hospital-Acquired Condition, or HAC, reduction program, which started in 2015, is a Medicare pay-for-performance program which supports CMS's efforts to link payments to quality. The total HAC score is based on 6 quality measures, 5 of which are HAIs. Now, hospitals with a score greater than the 75th percentile, or the worst performing 25%, will be subject to a 1% payment reduction. This payment reduction, which occurs when CMS pays hospital claims, applies to all Medicare discharges for the fiscal year. Another item under the CMS Hospital Quality Initiative is the Hospital Consumer Assessment of Healthcare Providers and Systems, or HCAP survey. HCAP scores reflect the patient experience, including the cleanliness of the hospital, and the results are publicly available on the hospitalcompare.gov website. Poor patient experiences, such as those caused by HAIs, can negatively impact HCAP scores. The key take-home message here is that CMS rewards and reimburses hospitals based on their performance scores. And FYI, during this COVID-19 pandemic, CMS will not be counting quality data for the first half of the year for performance or payment. So let's take a moment now to look at a few issues around HAIs. Next slide, please. When a healthcare worker makes a medication error, process issues aside, that healthcare worker knows without a doubt that they were the source of that error and they never forget it. However, when that same healthcare worker breaches infection control, such as a missed hand hygiene opportunity, or fails to disinfect a surface or an item when indicated, because of an incubation period, that healthcare worker will go their entire career without ever realizing that their action or inaction resulted in patient harm. In terms of cleaning and disinfection, clear accountability too often is missing. There needs to be very clear guidance as to who cleans what, when, and how. The recent introduction of cleaning accountability or responsibility grids is one solution to this issue. An exercise that I encourage participants to conduct is to take members of your healthcare team into a room or an area. Be sure to include all disciplines from nursing, EVS, respiratory therapists, etc. Go item by item and surface by surface, and be sure to include mobile equipment and ask the team, who cleans this and when? It's eye-opening to learn just how many things are not being routinely cleaned because of a lack of assigned ownership. And a side note regarding mobile equipment, the same opportunities that staff who are mobile have for performing hand hygiene should apply for the cleaning and disinfection of mobile equipment. And with that, I'm going to turn it over to Dr. Spina, who will share the key findings of a study on this very topic.
Fantastic. Thank you very much, Do. So I run a research program, or lead a research program evaluating technology and clinical practice and the impact that technology has on patient care outcomes. We realized over the years that hospital communication is essential, and it's very important as we break down silos and across the continuum that hospital communication occurs seamlessly. We know that people use smartphones, smartwatches, and wearables in trying to communicate in a timely, efficient, and impactful way as the patients transition through our care team. But as communication needs expanded, we realized that we were bumping up against some of the infection prevention and control policies. As anybody who goes up onto the wards will notice, clinicians are regularly using personal devices or corporate devices, and as Doe mentioned previously, we are not actually cleaning them in a regular manner. So I was fortunate with this trial to lead it with Ms. Stephanie Huffman and Ms. Carly Webb, and it's called the iSwipe trial, which is the investigation into cleaning methods of smartphones and wearables from infectious contamination in a patient-cared environment. We endeavored to actually perform a real-world clinical trial that looks at real data and how it's being used in clinical practice, and I'd like to present that to you now. In our publicly funded healthcare system in Canada, our team felt a responsibility to put data to some of the impacts that technology has on clinical practice. We know that in Canada, hospital-acquired infections affect 1 in 10 patients, and evidence shows that bacterial contaminants can live on inanimate objects and surfaces for months. So the purpose of the iSwipe trial, which was a prospective before and after study, was to determine if UVC, also known as ultraviolet C, disinfection devices are more effective at eliminating bacteria on smartphones and wearables compared to usual care. We actually did this at 3 hospitals on our island, Vancouver Island, Campbell River General Hospital, which is a community hospital, Victoria General Hospital, an acute care hospital, as well as the Royal Jubilee Hospital, which is an acute care hospital. And what we found is, using a baseline questionnaire, when asked about the frequency of cleaning devices, 45% of our participants said they clean their devices at least weekly, and that's their smartphones. 61% said they clean their smartwatches weekly, and 29% said they clean their badges weekly. Until recently, many of the manufacturers of the technologies stated that the IoT devices cannot withstand disinfection with conventional germicidal wipes. So we looked at using UVC through a product called CleanSlate, and it used ultraviolet germicidal irradiation, also known as UVGI, which is basically a disinfection method that uses short wavelengths of ultraviolet light, UVC, to kill or inactivate microorganisms. And it does this by destroying the nucleic acids and disrupting their DNA and leaving them unable to perform vital cellular functions. And we did this in a real-world setting. The CleanSlate device is a little glass box that actually has ultraviolet light permeating through the box, and you put your device inside that. What we found is that 22% of the devices grew bacteria prior to starting this. And then what we did is, when the participants started using the device twice a day during their shift, 20% of the devices grew bacteria. We put those devices into the UV box, if you will, the CleanSlate device, and it reduced down to 4% after they came out of the UV device. And some of the thought about why it didn't go to zero was because, just like if you're at the beach, you'll have an umbrella and it protect you from the ultraviolet rays of the sun. If there are any crevices or cracks inside the cases, etc., in the smartphones, bacteria could still grow in it, which is why this was a real-world trial, to understand how different cases can affect the cleaning abilities, if you will. And the bacterial loads, if you will, of the smartphones were inoculated in a setting as well, where we actually used MRSA and VRE and inoculated phones that were going to be thrown away and discarded, and it was 100% kill rates on all of those devices as well. Finally, the participants found the device to be very easy to use. 90% of them were satisfied with the UVC device, and 95% found the UVC device to be very easy to use. We found that the Internet of Things and wearable devices grew pathogenic bacteria from 7 to 50% of the devices, depending on what they were. And ultraviolet lights appeared to be more effective at eliminating bacteria on smartphones and wearable devices when you compare that to usual care. And we feel that the results of our study indicate that this technology is beneficial in the hospital setting for Internet of Things and wearable devices. The one thing that we know is that, based on the results of our early trial here, further studies are needed to determine optimal interval at which UVC should be used. And where we go back to that is alcohol-based products were not used outside patient rooms 10, 15 years ago, and now they're everywhere and we're using them all the time. This is early evidence, and I think that the future is going to go this way. So I want to turn it now over to Daniel for the next piece.
So with this global pandemic that we're starting to see and really impacting Canada and the U.S., what we wanted to do is just get some real-world examples and some feedback from Sandra Dunford, who works for the Vancouver Island Health Authority, and the impact that SARS-CoV-2 or COVID-19 is having for the province of British Columbia, specifically in regards to infection prevention and control policies and protocols. So go ahead, Sandra. What's the impacts that you're starting to see in Canada?
So thank you, Daniel. I wanted to talk about the processes that we're seeing also in bringing in Sean's trial, particularly with the UVC devices, because I think that's a very important piece moving forward. So Island Health is the authority on Vancouver Island and provides delivery of care across the island for all residents, and it includes home and community, long-term, and acute care. The infection control team, when we were invited to participate with Sean, really were pleased to be invited because, as you are all probably aware, and as the previous discussions have noted, one of the major problems we're having is trying to engage staff to recognize and be able to understand the importance of cleaning and disinfecting the medical devices, whether they're personal or professional. When we're looking at the Spalding classification for non-critical medical devices, we do see that they have to be cleaned and disinfected, mostly between use. And because people are carrying these devices all through their work within a healthcare facility, it is moving from place to place, patient to patient, room to room. And this creates an opportunity for infectious microorganisms to be transmitted within that environment. I believe that the COVID circumstances that are happening currently are indicating that we really do need to step up and ask people to take ownership of the ability to contain microorganisms when they're working in a healthcare environment. Thank you.
Thank you so much, Sandra. Based on what we just heard of the impacts COVID-19 is having in Canada, we'd like to also expand that specifically the SARS-CoV-2 virus or coronavirus and the impacts it's having in the U.S. And Dr. Burbury, it would be great to get your input on your outlook and what you're experiencing in the U.S., and then from there some of the potential gaps for implementing infection prevention control policies and protocols that you are experiencing at Mayo Clinic, considering Mayo Clinic is in 3 of the states, one of them being a hotspot, Florida. So,
thank you, Daniel, for having me. So let me start off with giving a little bit of an outlook on the situation in the U.S. and how we started as of January of this year. Since the early report of cases in the Wuhan province in China, the first U.S. documented case was on January 20th of this year. Subsequently, the WHO later this month declared the COVID-19 pandemic as a global public health emergency. After that, things accelerated and the death toll in China started to increase significantly. On March of this year, the WHO declared the COVID-19 as a pandemic, and multiple countries have banned travel across the oceans and across countries. We started seeing during this month an increasing number of cases throughout the United States, but mostly in California, in Seattle, and in New York. And pretty much most of the U.S., most of the numbers in the U.S. started to increase significantly. As of now, maybe a couple of days ago or yesterday, the U.S. has had more than 830,000 confirmed cases and in excess of 45 or 46,000 deaths. A lot of the cases and deaths have occurred on the East Coast, the West Coast, and part of the southern state, Florida, as well as Louisiana. Before I dive into the situation in my hospital and our healthcare system, let me just give a brief description of how COVID is transmitted. COVID is predominantly, the SARS-CoV-2 is transmitted through droplets. And it could be transmitted through direct or indirect contact, but predominantly through droplet. Occasionally, it can be transmitted through airborne or droplet nuclei. In the Mayo Clinic, multiple teams were activated early in the crisis in January and February, including the Hospital Incident Command Center, Infection Control, Occupational Health, and multiple departments and divisions were activated to respond to the crisis. We are now at a point where we have almost universal masking and of both patients and healthcare providers. All patients who are suspect of having COVID or having COVID are placed in modified droplet isolations. Some of the barriers that we've identified to implementations of PPE and infection prevention practices have been around supply chain and availability of masks and eyewear and eye protections. Another barrier was being nimble in transforming infection prevention practices pretty much 180 degrees on what we've known in the past. We've also heavily relied on testing, including PCR and serology over the last a month and a half, and have implemented a program around utilization of testing to identify, detect, and isolate patients as well as employees. Contact tracing of employee and employee exposure has been significantly minimized as a result of implementation of wide-scale PPE as well as targeted testing and serology. What I'd like to do next is focus on some of the 4 steps around protocol design that were helpful to our institution and might be helpful to your listeners. There are 4 key elements of creating an effective infection prevention and control protocol. The first one is to gather key clinical and other staff to examine interaction points in healthcare workflow in order to identify gaps. So identification of gaps is so important. And then the second step is to establish a specific decontamination ownership of those potential gaps. The third step towards a clearer protocol is to establish and implement nimble, and I want to underscore the word nimble here, and real-time protocols for clinical staff. This was so important in the COVID-19 response. And lastly, is to ensure that technology acquired for in-hospital use is designed to withstand the requisite aseptic rigors of the healthcare environment.
So Sandra, based on what's happening in the U.S., we wanted to just discover and explore a little bit in regards to some of the effective prevention and control protocols that you're starting to see in Canada, specifically in Vancouver Island Health Authorities, when it comes to IoT and IT devices, and we'd like to hear from that. Hear from you for that.
Thank you, Daniel. As I'm sure we all are aware, the amount and the complexity of technological devices, mobile devices that are coming into healthcare is exponentially increasing. Infection control has striven over the last couple of years to try and keep pace with that. Unfortunately, because of the lack of understanding that they have the ability to transmit, it means that people aren't aware, and we often, before we know they're even coming, they're there. So what has happened with the iSwipe trial is it's allowed us to bring through the collaborators that we need to have at the table to develop the processes that need to go into cleaning and disinfecting non-critical medical devices, and also to engage staff so that they're thinking about it, and they can even think about what's going to happen when they go home and how they're going to protect their families when they go home. So when we're talking about establishing protocols and new protocols in particular, we have found it's very important to tie it to already familiar pieces that are in our policies and procedures and protocols in our island health. So when we were looking at the eye swipe or bringing in UVC technology, we tied it very specifically to hand hygiene and the ability to make sure that we are only handling medical devices with clean hands. So when Sean set up the procedure, it was involved with you have to wipe down the device before you put it in the machine because UVC needs to have the organic material removed. And then prior to taking it out of the machine, you performed hand hygiene. So the principle is always that you will only handle your medical devices when you have clean hands. Next slide, please. So one of the other important pieces to look at when we are talking about adding technology, cleaning and disinfection technology to healthcare facilities is to make sure that we have looked at the product and made sure that it actually can do what it claims to do. As you know, as technology increases, there are more and more vendors and products out there that make claims about infection control. It becomes essential to make sure that you've reviewed the claims and that they are valid and they do what they're supposed to do. I think the final point that I would like to make, and I think COVID has shown us this very well, is that there is no one fix to cleaning and disinfection and mitigating the risk of healthcare-associated infections. All of the processes, all of the technology that we bring into it is designed to work together. They are designed to be adjuncts to each other's process so that we create a very broad process that hopefully will provide the best process that we have for making sure that our devices are not fomites for transmission of microorganisms. Thank you.
Thank you so much, Sandra. So we would like to transition to Do, and Do, it would be wonderful to hear about an ATP study that you were able to do specifically around infection prevention policy.
Thanks, Daniel. Yeah, this wasn't a traditional study. It was very impromptu. But this occurred in recent years while I was still a hospital IP. The infection control department, we'd finally received our very own ATP monitor so that we could, perform random spot checks around the hospital for cleanliness. One of the highest ATP readings that I've ever seen of all items tested throughout the hospital was the touchscreen control panel for the department printer of all things. The RLU reading was in the tens of thousands, and mind you, we considered an RLU reading below 200 to be considered clean. This single example highlights the importance of considering the pathogens that could be harboring on the various touchscreens of all kinds of equipment throughout a hospital. If you want to reduce both HAIs as well as staff absenteeism, I recommend frequent cleaning and disinfection of mobile devices, computers and keyboards, and office equipment, including those printers.
Thank you so much, Do. So when it comes to healthcare edition type devices or healthcare specific purpose-built devices, it's really important to note that not only is it important to build devices that can withstand those caustic germicidal wipes that you just referred to, but also when it comes to thought leadership is HP has worked with Clorox, so that's Do that's on the call, as well as APIC, which is the Association for Professionals of Infection Control and Epidemiology, really to set the standard and as well as give guidance for how to sanitize devices that are in these healthcare settings. And what's critical we're finding is, especially in this COVID-19 outbreak, is we're getting a lot of questions on specifically regarding, how do we sanitize these devices and what types of germicidal wipes will be effective. And so we've been able to partner with APIC to be able to provide that type of guidance, as well as provide webinars such as this to share with nurses that are on the front lines. So we so thank the nurses and the physicians and our care providers on the front line, and we want to provide as much as possible the guidance in specifically regarding sanitizing IoT devices such as printers or IT devices that are often overlooked. So in the past, often IT departments who are responsible for IT devices or IoT devices are uncertain how they should move forward with sanitizing, and to be able to truly provide recommendations and protocols. HP has worked with APIC, like I mentioned earlier, which is the Association for Professionals of Infection Control and Epidemiology, to outline how you would sanitize these devices and the correct methodology. In doing so, we have done a webinar, and we've also provided a white paper so that IT can work with their epidemiologists. We can work with the IT departments of a health system, as well as work with environmental services. So with that in mind, we would also like to talk about our partnership with Clorox, which is the leader when it comes to germicidal wipes in healthcare systems. So with HP building purpose-built devices to withstand these caustic germicidal wipes, that is critical to following through with infection prevention policies and protocols, we have also partnered with Clorox, who is truly committed to developing innovative and proven disinfection and sanitization solutions. And Doe, it would be great to hear some insights specifically around our partnership with Clorox Healthcare.
Sure, thanks, Daniel. You know, as Sandra noted, in the coming years, we're only going to see more and more mobile and other IT devices used in healthcare. In fact, with the COVID-19 pandemic, healthcare experienced huge increases in the use of telemedicine, which relies on such devices. And I predict that in the post-COVID-19 world, the use of telemedicine is going to remain at very high levels. I, for one, am truly grateful for the partnership between HP and Clorox, in which we collaborate to provide the best possible solutions for the cleaning and disinfection of these critical healthcare tools. The industry definitely needs more collaborations such as this. Back to you, Daniel.
So as you know, IT and IoT devices become more prevalent, to truly help clinicians improve their efficiency, as well as be provided for the entire care continuum, like Doe mentioned, specifically around telehealth. It's really critical that that vendors and companies that are producing or developing hardware specifically look at these types of factors when it comes to being able to sanitize and disinfect devices that are going to be utilized with the clinician in mind. And when specifically around healthcare-associated infections or viral pathogens, specifically with this pandemic, it's really important to understand that when it comes to developing technology, you know, to keep the patient at the forefront, because that's what really this is all about, is providing safer, smarter, and more secured technology that is outcomes-based and can be sanitized and disinfected. So we would love to move this forward with Lily and hear some of the questions from our webinar.
Thank you, presenters. Let's get to questions now. Daniel, why don't we start with you, the question about wearables.
You bet. Thanks, Lily. So wearables is, we're starting to see these more prevalent. Wearables would be a smartwatch. It could definitely be a smartphone or some type of edge compute device that you would wear on you, hence they're called wearables. The other, these devices are called IoT devices or Internet of Things devices, and so they are always connected to the internet or either Wi-Fi or a cellular connection. And so because these are becoming more and more prevalent, I think it's very critical to understand that these can be another source or another vector of cross-contamination of viral pathogens or HAIs. So I hope that answers one of the questions.
Oh, that's great. Thank you. Doe, how about the question here, what factors must we take into consideration in regards to surface compatibility?
Oh, that's a great question. There are many factors that go into that. We have to look at the active ingredients in the disinfectant as well as the other components that make up the disinfectant, so the solvents and the surfactants and the other additives. We have to look at the types and the varieties of surfaces that we're having to clean, how the device is being used, and how frequently it's being cleaned, as well as the protocols. And then, of course, poor design of a device does impact compatibility negatively.
That's really helpful. And while we have your attention, there's a question here about accountability. No matter how good the policies and procedures are, accountability is personal, it's individual. How would you respond to that? Because that's a dilemma we all face no matter where we work.
Yeah, that's another great question, and it's a thorn in every infection preventionist's side, from getting them to perform hand hygiene as often as they should to cleaning the equipment. And I agree, it is problematic. But I think accountability starts with, but it does not end with, solid education. And there's got to be a competency piece. I mean, think about, we've all taken a CPR class. When you're sitting in that class, you're getting didactic, you're getting hands-on, you're taking a test and a quiz. I mean, just about every way to test competency is performed in a CPR class, and I think we need to do that more in healthcare, including, how we clean things. We need to not stop there, though. We need to make sure that we're monitoring compliance, and we need to do that frequently. And then we need to assess when we are doing that monitoring for compliance and we're not seeing it being done, we need to assess, have very comfortable conversations with our staff about what's the barrier. And we may find it something very easy to fix, and it may be complicated, and that's something we're going to have to tackle. Another way when you're monitoring compliance, you can do things like make it visual, like those fluorescent markers, so folks can see. It's like being able to see the germs, right? See what they missed. And then last, I think with accountability, there's this thing I call WIFM, and it's the what's in it for me. People have to understand, until they own it, the what's in it for me, they're not going to do what they need to do. And so here I would say we need to teach them about these pathogens, about how they're transmitted, and that cleaning these items and surfaces is as much about their safety as it is the patient's safety. And then last, given what's at stake for everyone involved, are we at a point where we need to start maybe putting a little more teeth into our policies? So that's what I'd have to say about that one.
Hey, could I expand? Oh, sorry.
Go ahead.
No, I was just going to expand on that, Doe. I'm glad you brought that up, the accountability portion, and to see it in practice. I know one methodology that, when I was at a previous health system, that we would have different groups of environmental services as well as the nursing staff and other care providers, healthcare workers, so MAs and LPNs. They would go and they would follow sanitizing a room. And it was interesting and IT would participate too, to see what potentially was missed and the way people would read or understand what should be sanitized and not. And then following through with a matrix so that everyone understands, hey, I have ownership over this, and this is we can't just assume someone else did it, right? So I thought I'd share that best practice. Yeah.
And Daniel, this is Sean. I just want to say it's one of the impetuses behind the research that we've done is actually just that, putting data to a process in the hospital so that people can actually see what is missed or how bad the situation is, to give them information to make a decision about what they're going to do for their own person when they're on shift. And that's one of the reasons why we do what we do with the evidence and the practice and model that we have.
That's That's great. Any other comments about accountability, which is the hot topic these days? Well, let's move to the whole issue of UV lights. Sean, you know, we were talking when we were formalizing this particular educational piece, and I'm intrigued by how UV lights are used just in normal day-to-day practice, whether you know, it's nail salons to cure gel nail polish or whatever we use, you know, UV lights to look for bed bugs, if you know what I'm talking about. And so we can really have a false sense of security when we think about UV lights. So you talked about your research. Why don't you expand on that a little bit, since we have so many questions about the use of UV lights? Which ones should we be thinking about, and which ones shouldn't we use?
Yeah, thanks for that question, Lily. So there are a variety of UV lights out there for a variety of purposes. We have to remember, in the spirit of what we're talking about here, is using UVC for the purposes of disinfecting or neutralizing bacteria or pathogens. And the UV lights that are used in to activate or solidify gel nail polish, for example, or UV lights for other purposes out there, they're not. They may claim certain efficacy, but it's really important that you can confirm that it actually works. Because when you're trying to clean or disinfect a product that you're using in the healthcare system, it's important that you know that it works. So it's important to go to a bona fide, evidence-informed product that has actually been approved for that use by a governing body and has some evidence behind it. And so we have to be very careful that we just don't buy a cheap product that says it has UV and assume that it's actually sterilizing or disinfecting our devices. And it's important that we actually use the purpose-built product that has been shown to be effective at neutralizing pathogens, because as we know, there are multiple different arrays. There's UV A, B, and C, and A and B are usually what we will see outside in the sunshine, and C is usually filtered out by the ozone layer, if you will, so we don't get a lot of it to the surface. Anyway, so we have to just be careful what we buy.
So you and Daniel, I think, talk really well about sanitizing devices in the home, or the lay environment, so to speak, versus the clinical environment. We really ought to pay attention to that.
Yeah. Yep.
Sandy, our infection control for Island Health, I'd like to just add to Sean's comments, and that is that one of the essential pieces to UVC disinfection is that it has to be cleaned first. So UVC light, studies do show it does not penetrate organic material. So the essential piece to disinfecting with UVC light is everything has to be cleaned first anyway. So it isn't a quick fix like some people will claim it to be.
Agreed. And Sandy, along those same lines, one of the most important things, no matter how effective the UV light is good hand hygiene. So this augments good hand hygiene practice. It doesn't replace it. So I worry a little bit that people will just toss their devices and not wash their hands, toss them in these cleaning devices but not wash their hands. But you're right, they have to work in synergy. Good hand hygiene along with UVC and physically cleaning the devices before they get placed in there will result in a better outcome.
So important. We have a question here from a school nurse, and just want to try to address some of her questions here. But in thinking that we're all in this dilemma together, trying to learn as much as we can, as fast as we can, and as nurses, clinicians, and other scientists, we know the science and the evidence base has to drive our actions. So as we think about the school year that will be coming for most states, school is done for this semester and for this year. But I'm really impressed with the National Association of School Nurses that has a tremendous number of COVID-19 resources and educational types of opportunities and programs for school nurses. So that's just one resource that I would give to the person that has written in the question. And, you know, at the end of the day, we hear you. We absolutely hear you. And what else would you like to address here? Sure.
Oh, I was just going to add the Centers for Disease Control is another great resource for everyone, including schools.
Yes. Yes, I really think it's important that we are sticking to the science. There is a lot of fake science out there now. I think it's just tremendous the amount of private sector and government sector cooperation that's occurring to come up with solutions. But at the end of the day, we have to be very, very careful about what we're reading and what we're implementing to make sure that it's scientifically based. My chat box has dropped, so I can't see more questions. So if any of you can see some questions, please chime in.
One question I saw, mine actually just went off as well, but I saw before it went off was about what is the future of UV light boxes in island health. And what I can say is as a result of the work that we did with the iSwipe trial, it actually has informed a further deployment of this technology now that we know it has been effective, and we have a new hospital being built, and it's formally in that business plan to actually have this technology throughout the hospital, as well as we just built another hospital that actually we're putting the technology there. It's comforting to spend budget or money on product that has evidence behind it to know that it actually works in a real world setting. And so that's where we're sitting with ultraviolet light, and as I mentioned earlier, it will augment good hand hygiene practice, and we are putting a plan in place as a health authority to actually roll this technology out through our current device or hospitals as well.
Terrific, great. I'm glad for you, and I'm glad for your community that's going to get a new hospital with such great technology in it. Any other thoughts, faculty?
Lily, yeah, this is Joe. I did see a couple of questions asking what is an HAI. So if we didn't make that clear, it's healthcare-associated infection. So it's an infection a patient did not have when they came into the hospital. It's a lovely parting gift that they acquired in the hospital.
And it really is a costly and deadly problem.
Yeah.
Yes. And previously, I'm glad you said that, though, is because in the past, often they were referred to as just hospital-acquired infections, but now being so prevalent outside of the hospital with long-term acute care hospitals and SNFs and other ambulatory settings, nosocomial infections have had a much broader meaning. And I think that ties really into what this whole topic is about, trying to share best practices with this global pandemic. It's not just in the hospital setting. We're really starting to see that infection policy and protocols can be even in the home. When we're with our children and family and practicing safe hygiene, right? Sanitizing our surfaces. We don't need to use the hospital-grade germicidal wipes, but certainly just
And Daniel, you're breaking up on my side anyway here. This is Sean. I just wanted to say along the lines of what you were speaking about hospital-acquired infections and long-term care and homes, and one of the area where research is lacking is actually when we do have good policies in institutions, good hand hygiene policy, maybe ultraviolet light, other disinfections, germicidal wipes. How does that use? We've done a lot of research on real bacteria pathogens not being prevalent after the devices are cleaned, but how does that turn into hospital-acquired infections? Do hospital-acquired infection rates decrease? And we'd have to do a longitudinal study for a long period of time to do it, but I really see that is the next phase of research that has to happen, is by putting all this technology into place, how is it affecting the true hospital-acquired infection rates?
Excellent point. Any other key points we want to make with our audience? All right. Well, let me take this opportunity as your moderator to thank all of you, because as faculty and our panel, your insights have been very helpful and tremendous. I also want to thank our audience for joining us for such a robust discussion today, and we wish you the very best on this joint journey that we're all traveling together. Goodbye now.